Hi everybody, this is Carol from the STS. Thanks for joining today's webinar. This is the version 4.2 upgrade walkthrough. The call today is scheduled for 2 hours. We'll end early. I don't know if we will or not, but we can end early if we get through the whole form and get all the questions answered. But I was hoping to complete the form today, and that's why we have extra time scheduled, so we can go live in 6 days if you could believe it or not. So we're just about there. Let's see here. So on the phone with me from STS, I have Leanne Jones, Jane Hahn, Donna McDonald, and Addie Dolan. And then we have Dr. Dave Warmuth, who has helped us through all of the upgrades with the informatics part of the upgrade. And we have Melinda Offer, who manages our FAQ mailbox. So again, if you have your data collection forms open, is there a bad echo on my side, Melinda or Leanne?
I don't hear an echo, but I see in the chat box that there's an echo. If
you're hearing an echo, you may want to call back in. I'm not seeing anybody else put that in there. So you may want to call back in or reconnect on a phone line. Okay, so we're going to start the walkthrough section. Again, we'll start with the congenital defect repair section in M3. So if you wanted to open up your data collection forms, you can. Otherwise, I'll have them up on the screen for you. And then again, please use the Q&A function to submit your questions, just like we have been doing, and we'll get to as many questions as possible. I'm going to try to get through the entire form, the rest of the form today. Oops, I thought I had it. Let me get this out of here. Okay, there we go. Can you see my screen okay still? Okay, we're going to start here at the congenital defect repair section. This is just beneath the aorta section. To get to this section, you had to, I'm going to pull it up on this side. That's where I should have started. Sorry guys. In the operative section, you're going to see a question that asks about congenital defect repair performed in addition to the surgery. And you would answer yes to that question. So up here in the operative section. Way up here, we have, I think, yeah. So this is the operative section. This is beneath the valve section we talked about, the aorta section we've already talked about, and we get to the other cardiac procedure, other cardiac procedure, congenital procedure, except unicuspid, bicuspid, and quadricuspid. The reasons these are not collected here, because they're going to be collected in this other non-cardiac procedure section. So we're going to get through both of these sections today. So if you answer yes to this section, M3 will open. We'll get back down here to M3, and I promise we won't do this much scrolling for the entire presentation. That's painful. So we'll get back down here to M3. And in the data specifications, you'll find the list to code the congenital procedures that belong here. These will also be drop-down menus in your vendor software. So you select the diagnoses, and these are based off of the congenital surgery database. You would select up to 3 diagnoses, and you could select up to 3 procedures. You have to select no other congenital procedure for, I believe, 2 or 3, and then that will stop the next fields from opening. So if you select no other congenital, then 3. If not no other congenital, then 3 would open. So if you select no other congenital, then 3 will not open. All right, the next section is the other non-cardiac procedure. This is where we collect the endarterectomies, the other vascular, other thoracic, and the other category. We will get to if you select endarterectomy, here are your choices, and again, just yes planned, yes unplanned due to surgical complication, yes unplanned due to unsuspected disease or anatomy, or no. And then we get into the post-operative section. We did some changes in here, and I just want to go through these. Okay, and we'll get to questions in just a second. Post-operative section, patient expired in the OR, yes or no? If you answered no to this question, that is the parent to all of these questions. So if the patient did expire in the OR and you select yes, then you do not, that's where you would stop. Nothing else would open up for you to fill out. We added this field in here, peak post-operative creatinine level within 48 hours of OR exit. What was shown is that patients who have a whose peak post-operative creatinine is elevated within 48 hours have a worse outcome than those that elevate after the 48-hour mark. So the surgeons want us to start collecting that to kind of get a better gauge of how the cardiac patients are faring after surgery. This value here could be the same as this peak postoperative creatinine. So this first value, the peak postoperative creatinine level within 48 hours, is just from OR exit to 48 hours. This peak postoperative creatinine level prior to discharge is from OR exit to discharge. So it could essentially be the same value. So if that's where those two come in. They could be the same value, they could not be the same value. So you just have to check to make sure it's capturing 48 hours from OR exit, and this one is OR exit to discharge. And then platelet dose pack we've added in, and then FFP, and we just clarified that's plasma units. Okay, and then we get down here, we changed this up just a little bit. This is the extubated in OR, yes, no, or NA. If no or NA, then we're going to take the intubation date and time. Initial extubation date and time, and the total post-op initial vent hours will be calculated. Total post-op initial vent hours is calculated from OR exit to initial extubation date and time. If you're ever looking to figure out how something is calculated, you can find these definitions in the software specifications posted on the web page, and we can go through that again where those are all located, but it's underneath the version. You would find this specific one underneath the version 4.20 data collection documents. Okay, and then we get into the post-op echo performed to evaluate valves, yes or no, and for paravalvularly, we added in the option for NA for the aortic and mitral valve for patients who do not have prosthetic valves. And then we get into the post-operative event section. This is changed quite a bit. Let's see here if I can pull up. So we got rid of all of this wound intervention business and kind of did a little reworking here. You'll see here we have surgical site complication during post-operative period up to 30 days or during initial hospitalization. The choices for this question are yes infectious, yes non-infectious, yes both. If you select yes infectious or yes both, then you need to provide some more information regarding superficial sternal wounds, deep sternal wounds, thoracotomy, conduit harvest site, or cannulation site. If non-infectious or both, then there's this non-infective surgical wound dehiscence. We were getting, so that's where you would collect if it was superficial or deep sternal regarding non-infective sternal wound dehiscence. And then there's this tricky little question here that we've gotten quite a bit of feedback, and it deserves some time to talk about it. The question is there evidence that the patient had a deep sternal wound infection within 90 days of procedure? And the choices are yes, no, or unknown. The CDC guidelines for collecting deep sternal wound infections, it includes a period of up to 90 days post-procedure. The STS has historically only collected within 30 days of procedure, or 30 days, but during, greater than 30 days, but during initial hospitalization. Sites have asked that we start aligning with the CDC or so they can compare their outcomes within their site. So we added this field in. We do not expect sites to follow their patients for 90 days. So we do not expect sites, again, we do not expect sites to follow their patients for 90 days in this version. If sites want to capture this, then you should be consistent in capturing it, and you should capture it on every patient. If your site does not want to capture it, then you would just select unknown for these patients. This is for version 4.20. In the future, I do not know if we will start wanting, if for the next version, which will be 2023, I do not know if at that time we're going to say we need to align with the CDC definition and we need to go out 90 days. But for this version, it is not required for sites to follow their patients for 90 days. So I hope that that's clear. It's here. If you don't know the answer, select unknown. I ask that you be consistent. If you're going to follow patients, then follow all of your patients. If you're not going to follow all of your patients, then I wouldn't even, I would just select unknown for your patients. Unplanned coronary artery intervention. This field used to be called, where did it go? Reintervention for myocardial ischemia. And then we, I think we kind of changed that up because we were seeing some, it kind of was getting confusing with some of the things that were coming in. So the surgeons thought that we would just rename this unplanned coronary artery intervention. And then we have, was it native, graft, or both, and what type of intervention was performed. And then we removed the positive blood cultures for sepsis. TIA is removed. We are collecting, let's see where it's at. The encephalopathy, we're just collecting encephalopathy. And Melinda, is it correct that we're no longer Melinda, are you there?
I'm here.
We're no longer collecting the delirium.
The delirium's in the anesthesia module.
Great, okay, that's what I thought. So we're gonna collect encephalopathy here. The delirium, if you participate in anesthesia, the anesthesia module, it's down there. Notice we got rid of some of the granularity here. So post-operative stroke, yes or no. Encephalopathy, yes or no. If you want to get granular on that, you could work with your vendor software to break that down. But for purposes of STS, we're mainly interested in the stroke, not the type of stroke. We will get down to the bleeding section in just one second here. And then for lower extremity paralysis and paresis, we were collecting transient and permanent. What we were really interested in is if these were lasting greater than 24 hours. So we adjusted those, and it's just, did the patient have paralysis or paresis greater than 24 hours? Yes or no for both of those questions. And then we get into the prolonged ventilation, which is your initial ventilation time plus any reintubation time greater than 24 hours. If that's a yes, then we added this question in here regarding tracheostomy required after OR exit, so that the patient have to have a tracheostomy placed regarding their prolonged ventilation. Let's see here. Some of the things that were removed, the surgeons, we either had very low frequency on them, or we just were not, there was no reason to continue capturing them. Most likely it was the low saturation on the fields, or that they didn't have any impact in with the outcome, what we were measuring for outcome. So we just no longer needed to collect those. We got into the mechanical assist device section, kind of clean this up a little bit. Oh, made it all, select all that apply. So you have the mechanical assist device related complication, and then you could select all that apply. The choices are still the same. Just select all that apply for that. And then other disturbance requiring pacemaker. They didn't really want to know what type. They just want to know yes or no. So again, if your facility wants to know the type, you could have your vendor software add in a field. I know you don't like hearing that, but for purposes, for the majority of folks using the database, all they really want to know is yes or no for this field, and all the other information can be easily, or I don't know how easy, but could be pulled out from your EHRs. We had the anticoagulant bleeding event. So this is 6929. This is prior, it just was an anticoagulant event. So what we're looking for is, was it a bleeding event? And this is where we'll capture the intracerebral and subdural bleeding, and also the GI bleeding related to a patient being on anticoagulants. And then we broke this section out a little bit. I'm sorry, I'm going to go back up here to the aortic complications. And this is a yes or no. If you have any aortic complications, then you answer these 4 questions. If not, then you don't see these questions. You shouldn't need to answer those. They won't open to answer. And then we have the heparin-induced thrombocytopenia HIT, and then the HITT. So if the patient tests positive for HIT, was the patient positive for heparin-induced thrombocytopenia thrombosis? Sometimes we get these results back after the patient goes home, and it's still okay to code them after the patient. If the test was drawn in the hospital and the patient goes home, and then you get the results back because it has to get sent out to another facility, it's still okay to code that here. And then for the gastrointestinal events, we kind of clean this up a little bit. GI event, yes or no, and if there was a GI event, this is where we'll capture ischemic bowel, the GI bleed. And it's okay if you have a GI bleed that's selected to or connected to an anticoagulation event to capture it in both spots. Pancreatitis, cholecystitis, liver dysfunction, failure, ileus, and other. We're almost done. The discharge mortality status at 30 days after surgery, either discharged or in hospital. This was just added in for clarity. That's always been the definition, but that's just added in for clarity. And then we added this question in here because in version 2.9, we said that we need to follow patients who are transferred to another acute care facility on the same data collection form. And once they're discharged from the acute care episode, no matter if it's your hospital, the second hospital, or the third hospital, that's then when you would capture the post-operative, finalize capturing the post-operative events. So whatever happened at the other hospital, if they were transferred from your hospital, would need to go on this data collection form. So instead of, so that still is going to happen for version 4.2. So to kind of help sites not fill out this information, the question is here. And if you answered yes, that the patient was discharged to another acute care facility, and you can put in the transfer date, this is like a hold for you. So you know that you need to go back then and keep a track on this patient. None of these fields will open. None of these discharge fields will open. Once that patient then gets discharged from the acute care stay, you can go and check no, and then you can, oh, I'm sorry, I lied. This is the part, then when you get down to this question, is the patient still in the acute care setting? Yes. When you answer yes to this question, that's the hold. So we still capture the date because sites wanted to kind of track when patients are transferred out of their hospital to another acute care hospital, the date that they were transferred. So this will then be your own facility's length of stay. And then we have, is the patient still in the acute care setting, yes or no? If you answer yes, then this this grays out. You would not be able to answer that. Once the patient goes home from the acute care setting, you answer no, and then you would be able to fill in this information. Hospital discharge date. the status at hospital discharge. We did a change here, and I want everybody to listen up because this is going to affect a small number of people, but I think it's important, or a small number of cases, actually less than 0.5% of cases. But I think it's really important to understand how this works for everybody. The status at hospital discharge, we have 4 choices now instead of 3. We have discharged alive, last known status alive, other than hospice. This is any hospice. This is outpatient hospice, this is inpatient hospice, and this is at-home hospice, right? So not outpatient hospice, but hospice at another facility outside of your own facility. So discharged alive, last known status alive, other than hospice. Discharged alive, died after discharge. Discharged to hospice, and died in hospital. Patients who are discharged alive, died after discharged, discharged to hospital, discharged to hospice, and died in hospital. Discharged to hospice and died in hospital are counted as operative mortalities. So these 2 fields here are counted as operative mortalities no matter when this patient who's discharged to hospice expires. Now, if this patient is discharged to hospice and has a wonderful recovery and actually gets discharged from hospice, then you need to reach out to STS because we have to verify, the surgeon leaders want to review those cases. So we have discharged alive, last known status alive, other than hospice. Once you select that, then the discharge location will pop up. If the patient was discharged to an acute care, an extended care, transitional care unit or rehab, then we'll ask, was it an acute short-term rehab, a long-term rehab, or unknown? This was added in to break up these discharges a little bit further so we could get a better understanding of where the patients were going and what the intent was at discharge. Patients who are discharged to acute care, acute short-term rehabs have a much different disposition than patients who are discharged to long-term rehabs. If the discharge location is not left AMA, so the patient was not left against medical advice, then we're going to collect these other fields. This is a change from version 2.9. We previously were capturing all of these fields. That's on patients who left AMA. We kind of got the surgeons to agree with the core group that we should not be penalizing sites or surgeons for patients who left AMA. So we have these fields then will not apply to those patients. Now, patients who were discharged to any of these other locations other than left AMA, you'll need to fill out these fields. The cardiac rehab referral is the same as it was. There's great clarification in the training manual. I suggest making sure, especially in the time of the COVID, that you understand the COVID pandemic, that you understand how we're guiding you to capture this field. And then we have the substance use screening and counseling. This is an NQF measure. I believe it's 2795. I think I had the number wrong here. Is that right, Melinda?
I'm sorry, challenge with the mute button. It's in the training manual, and the number on the data collection form is wrong. I know that. So yeah. I think it's 2795.
I think it's 2795, and I'll update the number on here just prior to go live because I have one other thing I need to add in to the data collection form. So substance use screening and counseling performed. It's NQF 2795. Yes, no, not applicable. What this NQF measure is, and this is all in the training manual, what this NQF measure is it's asking, did the patient, there's 3 items on here that this is referring to. It's referring to tobacco screening, alcohol use, and non-prescription opioid or non-prescription pain medication use. If you have to screen for all 3 of those, if the patient screens positive for any of those, then they need to receive the appropriate counseling. It's an all or none measure. So you have to screen for all 3. If the patient screens positive for any of them, you have to provide counseling, or there has to be documentation that counseling was provided on the part of that measure that the patient screened positive for. So if you have a patient who screened positive for tobacco use, was screened negative for non-prescription opioid or non-prescription pain medication use, and screened negative for alcohol abuse, you provided screening on the positive part of that, which was the tobacco, you could code this as yes. If you had a patient who, same patient screened positive for tobacco use and negative for the other two, and no counseling on tobacco abuse, no counseling on tobacco use was provided, then you have to code no. So it's an all or none measure. Any of those three that they screen positive for, they have to receive counseling on, and then you can code yes to it. And this is in the training manual. It's really laid out well, and I'll update this number on here. And then we get down to the medications prescribed at discharge. And we have aspirin, ADP inhibitors, other antiplatelets, all fall under the antiplatelet category. And then we have anticoagulants. In version 2.9, we collected factor 10A inhibitors and novel oral anticoagulants. And these were actually, it's interesting because some factor 10A inhibitors are now novel oral anticoagulants. So sometimes we were double capturing these at sites when there's the overlap between the medications. And so in order to get away from that, we are just going to collect this direct oral anticoagulant field. We'll still continue collecting warfarin and other anticoagulants. The ACE or ARB, we added, we'll add some clarification. There's clarification in there when to code not indicated for these for an ACE or an ARB. So make sure you refer to the training manual as you start to abstract these fields. Now, if the patient was discharged alive, died after discharge, or discharged to hospice, there's the mortality date. Patients who were discharged alive, died after discharge, or discharged to hospice, the operative mortality, yes or no. All discharge to hospices are operative mortalities. So no matter when they expire, when the patient dies, they're considered an operative mortality. This will be an inconsistency. If you code discharge to hospice and you do not code operative mortality, it will be an inconsistency and you won't be able to submit your data to IQVIA. If you have a patient who is discharged to hospice and that patient ends up recovering completely and ends up going home, or gets discharged from hospice to another level of care, then that's when you would need to reach out to STS, and we'll have to review it with the surgeons, and then they'll provide us guidance on how to code that. Otherwise, it will be counted as an operative mortality. If status at hospital discharge, and again, this is a really small number of patients. I think it was less than 0.4% of all cases out of 300,000. It was less than 0.4% of all cases. So it's a very small number. But we have had instances with version 2.9 that the surgeons decided that it was necessary to change how hospice patients were being captured. If status at hospital discharge is discharged to hospice or discharged or died after discharge, then we want to know the discharge death location. And if died in hospital, then the primary cause of death, and you have the systems here. For readmission, no major changes here, just readmission, yes or no, the date, and then the primary reason. We did add wound sternal dehiscence not related to infection as another primary reason choice. And no changes in the procedures. And I'm going to run through the anesthesia section real fast here. We've just been on this call for a half an hour. There's about 50 questions. There's about 50 questions in the Q&A, so just take a few minutes to run through this so we can get it, knock it out. We did put a parent field here. Organization participates in the adult anesthesia section. This will, if you code no to this, this whole section will gray out, and it will not show up as missing on your data quality reports or in your other reporting section, the missing variable report on the IQVIA platform. We added here the ratio, so CRNA, if there's an anesthesiologist medically directing CRNA or directing an AA, then the ratio, anticoagulation prior to prior to bypass. We have heparin prior to CPB, yes or no. If yes, then they want the dose. And they also want to know if the patient required antithrombin 3. For patients who did receive heparin prior to CPB, did they require antithrombin 3 prior to CPB? And the dose of that. And the bivalirudin and argatroban are captured, as well as anticoagulants prior to CPB. And then we get down into the volatile agents and select all that apply. No major changes here. We just collecting Versed, fentanyl, sufantanil, and Remy. And then the multimodal, this is a new field. We're looking at controlling post-operative pain without opioids, and this is the multimodal analgesics and the types of medications that were used, and they're listed here. Select all that apply. This is from OR entry to 24-hour post-op. Core temperature source in the OR. We added a couple options here that match the operative section in the regular data collection form. And I think it's pretty much explanatory. The albumins that we're capturing 5%, 25% given by anesthesia. Albumin, the totals, sorry, and then ANH and total of that, and then inhaled. This was the vasodilator. I think this was named something different before, but this is intraoperative inhaled vasodilator, and was IV vasodilator used. They're asking for sizes on the left atrial. This is post-induction pre-incision TEE. If that TEE is performed, then these fields are asked to be filled out. They asked for this left atrial size, superior, inferior, medial, lateral. These are really difficult, not always documented. If you have them documented, then please fill them in. I know that they're not documented all the time. And then they wanted to get a little bit more granular here on, this is the CPB used and the type of management used during cooling and rewarming. And then if the arterial outflow temperature was measured. This is pretty much related to the what perfusion is doing. So this should be documented on your perfusion sheet, I believe. Types of 0.9 given, and then they added this in reason return. So patient is post-procedure TEE is performed. During any of those post-procedures TEEs, did the patient have to get returned to bypass? And if they did have to get returned, what was the reason? And these are listed here. The reasons are listed here. And if it was ventricular fail, what type of which ventricle failed? And this is the post-operative additional information. And the timeframes have been clarified in the training manual. We moved the peak glucose within 18 to 24 hours after OR exit time into the anesthesia section. The surgeons no longer wanted to collect it. It was a bad field that it's important information, and it's important to monitor your patient's glucose, but it's difficult to capture it in the database with the timeframes. So it was better for the sites to do that, measure that with themselves, and most sites already have great processes in place to do this, to measure the patient and monitor their glucose. And I think that's it for the data collection form. So I'm going to answer some questions and see how many we can get through. Melinda, do you have anything to add?
No, I'm here for questions. Ready to go.
Okay, here we go. When will the procedure identification chart be posted? So we're just waiting on one more thing from the surgeons that they're updating, and as soon as we have that on DCRI, we'll be able to finalize the procedure identification chart, and we'll be able to get that out to vendors for the risk model certification, hopefully within the next week. Section M2 is an area where my colleagues and I could use guidance. Will there be a time when you will review that? I'm guessing you did that last week before we were aware of these webinars. Yep, so we did review M2 last week, and it is posted online on the webinar page. Let me see if I can pull my thing over here. For those of you who don't know, because I know last week, the previous call earlier this month, we decided that we were probably going to continue the rest of the calls for the month to focus on the upgrade. So last week we did the same thing, and we focused on the aorta section. So that's why it was done last week and not this week, because we wanted to get through the whole data collection form prior to go live, which is in 6 days. So to find the recorded webinars, if you're not familiar with the website, it's sts.org, and then you would go to, the homepage will look like this. You'll go to Registries and Research, STS National Database, and scroll down just a little bit and you'll see View Live Webinars. And once you go here, you'll see the upcoming webinars that are planned, and then the past adult webinars. This one from June 17th that's labeled the user group call is the section M2 for the aorta section. Sorry, I moved that kind of quick. Okay. If a surgeon performs a CAB and a left atrial appendage, is the CAB considered an isolated CAB? Yep, left atrial appendages do not move it out of the isolated category. I'm confused. Where are you capturing the bicuspid valves? So, and I guess actually we went over the bicuspid valves 2 calls ago, and it's in the other non-cardiac section. No, I'm sorry, hold on. Let me get there. It's in the other cardiac section up here.
It's in the valve section.
It is?
Bicuspid valves. If they're doing a valve replacement.
Sorry. Oh my gosh. Okay, hold on. Let me just scroll up there real quick. I'll show you where it's at. I don't know why I said that other thing earlier. I know better. Sorry, everybody. Okay, so this is the aorta valve section, and they just get captured in here, Melinda?
Yeah, if you're doing a replacement for a bicuspid valve, you would capture it there. If you're doing, if the bicuspid valve involves a root procedure, then you would do it in the aorta section where you're capturing the valve and the aorta together in section M2.
Yeah. And we capture that as part of the etiology in M2 as well.
Yeah, I think they just got confused when you were going through the congenital, and I think the main point about the congenital that Carol was trying to make is we don't want valve morphology in the congenital section. So even though a unicuspid valve is a congenital issue, we want it to be captured not in the congenital section, but in the valve section.
Great, thank you for clarifying. Thanks, Melinda.
You're welcome.
Next question, is the final data collection tool posted, or do we use the April tool? I'm going to, there's just some things I need to clean up in here, like I need to add in the COVID fields because we'll still be collecting the COVID, using the temporary fields to collect the COVID data. And then I was just going to fix that NQF number. And I think we had one other, there was another spelling mistake or something in here that I needed to fix. So I was just going to clean it up a little bit, and then I'll post if there's any other, I'm not anticipating any other changes, but if there is, I'll highlight those. And I plan to, on whatever the last day of June is, the 30th, I plan to repost a final form. Nothing major, no major changes, just a few cleanups that we've caught in the review process as we've been going through these webinars that I wanted to make sure I updated. And then I have to add in those COVID forms. I also wanted to make sure the vendors are in the process of getting certified, and quite a few have gotten certified for phase 1. So as they've been going through the certification process, they've been reaching out to us if they have questions, and it's better to wait for a good portion of the vendors to get through certification, because they tend to pick up spelling and errors like that when they're doing their thing. So I wanted make sure I had enough feedback from them before I made changes, instead of posting 10 different data collection forms. So I should get a final one up in just probably the day before go live, but it won't be a whole lot of changes, major changes. I have a new data manager. What is the reasonable amount of time to abstract a case? Maybe a range, as I know there are more straightforward and more complex cases. Thank you. So Katie, I'm not sure what your background is, but there's a whole range of experience, and some people came from the OR, some people have come from the ICU, some people have come from medical records. Everybody has a different level of knowledge. In the data manager, this is the STS webpage and the research registries and research and STS national database. If you go down here to data manager education, you'll see the 2019 data manager survey results. And in these results, you'll be able to, we did these results from last year, you'll be able to find averages on how long it takes people to abstract. So I think that would be a helpful resource for you. And if Leanne, if you're listening, if you could put my email in the chat box, and Katie, if you want to reach out to me, Melinda and I can help you with any questions you have. Next question, as we go live in July, can we enter data directly to the website? Yeah, if you're interested in using direct data entry, we actually, Jane Hahn and the rest of our team, we're putting together a demo tomorrow, and I know she was taking names. If you want to send your email address to her, hold on one second. I'm going to put there's my email address, and then if you'd like to STS.org. Oh, if you'd like to send in your email to stsdb@sts.org if you're interested in that direct data entry, please email Jane tonight or very early tomorrow morning so she can get you that information. Where can I find the data collection form showing the upgraded changes? So if you're looking for the form with the blue, that's on the website. If you're looking for the form with the tricolored form with the yellow green, please email me and I'll send it to you. I didn't post it because there were changes made to the blue form, the one with the blue form after that were not made on that tricolored form, so I didn't want to confuse anybody with any discrepancies. But I'm happy to send you the form, even though it's not perfect condition. So okay, yeah, if you want the form, the tricolored form, please just email me and I'll send it out to you. If a patient has a TOEFL repair as a child, like Ratstelli, did I say that right? Where this is just conduit between the RV and PA, and now is coming to have a pulmonic valve implanted, does this go in the valve section or congenital?
Put it in the valve. I put it in the valve section because we want to capture that pulmonic valve, and then the history, of the repair would go in the previous CV interventions.
And we capture the tough repair in the previous intervention section in the congenital.
It's I think it's actually, it's not, it doesn't say TOF repair, but I think it's other congenital, or trying to think the exact terminology. I'm scrolling on my data collection form.
know, I promised I wouldn't scroll, but here I am.
Well, it's hard because it's hard to memorize these sequence numbers. I've got some of them memorized, but not all of them. This one's 805.
I think it's this congenital cardiac repair surgical is where
Yes,
you would put it.
that's it right there.
Yeah, under other previous cardiac interventions, and then it would be this field here that you would code for that patient.
Mm-hmm.
Thanks. Why are you collecting the extubation time if the answer is NA, not intubated? We aren't collecting the extubation time on patients who are not intubated.
Seems like it wouldn't open up.
No, it won't open up. So I think it says, let's see what it says. Oh my gosh, the scrolling's going to give us all seizures. Okay, come on. I wish it would just go where I want it. So if no or NA, so if extubated in OR and you checked no or NA, these fields would not open up. If you select extubated in OR, yes.
This patient's not intubated. I think.
Did I get it wrong? I got to change this to yes.
Well, no, you got it wrong, but in her question, she's saying the patient was never intubated. I'm trying to look on the data collection form right now. I think
this is right. I'm sorry, I said that wrong. So if extubated in OR is yes or NA not intubated. Oh, you're saying the NA not intubated should be there. Let me check that one out. If it's no, is Paul on the call? Is he listening to me?
Yes, I am.
Do you remember, did we already talk about having to remove this NA from this here from 6585?
So intubation sequence is 2253. So we have three choices. What? Yes, prior, yes, NOR, and no. So if you answer no, is that going to just automatically gray out that field, extubation field?
I don't think it's apparent. I think that's why the NA is there.
Okay.
Could be wrong though.
Let me check real quick.
That may be, that's what I think. I think it just will gray it out and it won't even show up if you're never intubated.
Let's see, 6580. So these are the data specifications. So I want to say extubated in OR, my choices are yes, no, or NA.
Yeah, I just saw it right there. It was right there.
Yeah,
Go back up to this data spec.
No or NA. There was a reason why we did that. Oh, I know why. Because
scroll right back up. You got your answer. There it is. Patient was NA is patient was not intubated in the OR.
Oh, okay. So they wouldn't have an initial extubation date and time.
Right. It wouldn't even show up. It would be like, yeah, they were never intubated.
You can't get to an initial extubation date and time unless you answered no, or I'm sorry.
No, this is incorrect. With this NA needs to be, this NA is not the right one, I think. See what I'm saying?
Yeah.
We'll have to talk about it, but I think
Yeah.
Kathy's right on here. I don't think that this NA is supposed to be here. I think it's just supposed to be no. Extubated in OR, no, which means that the patient left the OR intubated and they were extubated after OR exit.
Right, but you would answer NA if the patient wasn't intubated ever, and then those child fields wouldn't open up.
No,
Right.
it would open up the way it's programmed right now.
Oh, it is? What?
Yeah.
Oh, I
Yeah.
see what you're saying. Yep.
Yeah. So I think, and so for right now, we'll have to talk about it, but it's not, if we'll have to figure it out offline and come up with a solution on how to manage that with the going. We can talk after this call, Paul, and figure it out.
Okay.
Thanks, Kathy. I'm not sure how we didn't catch that. I thought we did.
Well, there is an on-save check for that is based on, well, it does check. I'll check that as well.
Okay, thanks. If you want, we can talk after the call to figure it out. Thank you. FFP PAC, can you explain that better, please? Regional leader, we discussed this. Some of our managers' sites are referencing. They have 8 packs, some 6 packs, some 10 packs. So I guess we have clarification in the training manual on that, Melinda, on the FFPs.
Yeah, basically a dose pack can consist of 4, 6, 8, or 10, or any number of donor platelets, okay? And so in that dose pack, so let's say you have 8 donor platelets in there, that's still one bag, okay? So that's one single bag. You're going to count it like bags. How many bags do you give the patient? A dose pack, a single bag is counted as one despite the number of platelet dose packs in the bag. Does that make sense?
Makes sense, because that's how the surgeons explained it, and that's why we changed it.
So it's really laid out in the training manual quite well, for those of you who didn't get that. But.
Next question. I noticed that the post-op peak glucose 18 to 24 hours has been moved to the anesthesia section. If we are not participating in the adult cardiac anesthesiology data collection, then this value will not be required. That's correct. Yeah, that is only required if you participate in the anesthesia section. Only sternal wound, next question. Only sternal wound dehiscence, not cannulation site. I'm not sure what that means, but hold on. So we have cannulation site here. So if you coded yes to infectious or yes both, you capture the cannulation site here. If that didn't answer your question, Cindy, please resubmit or clarify. Deep sternal wound within 90 days for discharge to other facilities makes this a dirty event. So again, this is up to you if you collect this or not. And if the patients are discharged to another acute care facility, you're still following that patient until they're discharged from the acute care stay. It would be preferable to mark 6749 optional on the data collection form.
That's the field for 90 days.
Just put unknown. If it's optional, just put unknown. So we do not follow patients for 90 days. Are you saying we choose unknown for deep sternal wound infections within 90 days or leave it blank? If you are following these patients for 90 days, then you should capture this as a yes. If you're not following all of your patients, you should be consistent in collecting these. Either you're going to collect it on everybody or you're not going to collect it on anybody up to the 90-day mark. So if you have a patient who, if you're collecting it on everybody, a patient does have a deep sternal wound within 90 days, then you would capture it yes. If you're not following all your patients, then you would just mark unknown on these patients. Are the operative complications within the visit that the cardiac surgery happened? So the operative complications, the surgical site complications, this section here within 30 days, and then this one is within the 90 days. So it's within 30 days or during initial hospitalization. And initial hospitalization can include if the patient is transferred from your facility to an addition to another acute care facility, you would capture these here as well, even if it's after the 30 days. These events down here that say other in-hospital post-operative events, this is for your initial acute care stay within your hospital or any subsequent acute care stays where the patient doesn't leave the acute care setting. So if your patient is at your hospital and they develop, pick something, I don't know, we'll just say that they had to go back to the OR for a bleed, then you would capture that. If they were at your hospital and then they didn't have any post-operative complications in this section, but you had to transfer them to another acute care hospital, and they had to go to the OR at that hospital for a bleed, you would capture yes. If your patient was at your hospital, didn't have any post-operative events, I know this is going to be the third example I'm going to share, and I think that I know it's you'll probably have to go back and listen to this again just to kind of digest it better. If the patient is at your hospital, they do not have any post-operative complications under this section. they get discharged out of the acute care stay, then they get readmitted, and they have to go back for re-op for bleeding or tamponade, you are going to choose no, because that happened outside of the acute care stay. I hope that if it's not clear, just feel free to put in another question. Assuming unplanned coronary intervention is still included in the NQF star rating measure for re-op bleeding or any other cardiac reason, correct? Yes. And unplanned coronary intervention is collected here, and this is, again, this maps to the re-intervention for myocardial ischemia, which was previously captured in this field. Same short name, just renamed the long name for that field. So it is still in the NQF star rating. Will trach required after OR exit replace coding re-op non-cardiac? Yes. So the reason why we added tracheostomy required after OR exit is because version 2.9 and previous versions, patients who had to have a trach, even if it was just placed at bedside with minimal resources, in order to capture that tracheostomy, we had to code that in re-op for other non-cardiac reasons. So we will no longer capture the trach in this field here. We are going to capture the trachs down here in their own field. Anything to add to that, Melinda?
Nope. Perfect.
Thanks. On the prolonged ventilation and was trach placed, do we still count? No, so same question. Do we still count this in the re-op no cardiac or re-op non-other cardiac section? No, it's just going to be captured here in this field, this new field. On encephalopathy, is this a new onset? Some patients have pre-existing mentation issues that may be worse for a few days until meds are adjusted and they are cleared by anesthesia. So we actually provided some pretty good clarity in the training manual on how to capture this encephalopathy field. And I do believe it is, we wouldn't want to capture this. It has to be diagnosed. I think, did we say it needs to be diagnosed by a neurologist, Melinda?
It does need to be diagnosed by a neurologist now to capture encephalopathy, because the surgeons really want to capture true encephalopathies.
Yeah, not those that are, not the patient who might have a little bit of ICU delirium or just having a hard time waking up from sedation that the hospitalist will code as encephalopathy. It needs to be diagnosed by a neurologist to code this field. Would you add a PEG insertion under GI event? You can capture it under GI event, but no, you don't need to. You don't really need to capture that. If you wanted to capture it, that is where you would capture it under yes and then other. But really, we're just interested in these 6 things here: the ischemic bowel, the GI bleed, pancreatitis, cholecystitis, liver dysfunction, and ileus. We added other because we know that we like to capture any complication. Sites like to capture any complication, so we just added the other, so you would have a place to capture things like that. Now that we are capturing tracheostomy within the, same question. So I thought we were told that AFib would be a separate field on this version, so that when it is the only post-operative complication, we won't have to go through and say no to all the other things. No. No, I don't remember saying that. There's a part in here that the AFib, if the patient, we added a question in the operative section or in the, I think it's the operative section that says, did the patient enter the OR in AFib, that would exclude it from the post-operative complication section. But no, we have to still go through and answer. No, we're not going to assume, we don't assume answers for these questions. They have to be answered for the post-operative complications. Would ileus be any post-op ileus just prolonged? Is there detailed in the training manual? I believe we provided detail in the training manual on that.
It is. It's an ileus that requires invasive treatment or increases your length of stay. So it's not all ileuses.
Right. The surgeons did a great job when we were doing the upgrade to provide some clarity. So Melinda was able to really bring in their notes from the upgrade calls to what the intents were for these fields. For the rhythm disturbance requiring permanent pacemaker, do the surgeons still want ICD if no pacer component? Code yes here in the new version 4.2, catching all yes or no's. Correct. Yep. So any rhythm disturbance requiring hold on.
A device. So it's all laid out in the training manual. So ICD pacer. It's pretty clearly laid out in the training manual.
It's not pace. Yeah, it's not just pacemaker. I wanted to find that section. Oh, it's an ICD. It's an ICD. Melinda.
It's laid out in the training manual. It includes ICDs, pacers, combo devices for a rhythm disturbance.
Thank you. Okay. Got myself confused. Please review the stroke complication again. Okay. Stroke is. So we're just collecting the post-operative stroke. We're no longer collecting TIA. So post-operative strokes are symptoms lasting greater than 24 hours. And I believe there's other criteria or other clarification in the training manual for things that could be coded as stroke. I believe that we use imaging.
Yeah, it hasn't changed. The definition for stroke did not change from 2.9 to 4.2. The things that's changed is we're just not breaking it down as to what kind of stroke it was, and we're not capturing TIAs anymore.
Right. Thank you. Is this a HIPAA violation, obtaining records from another acute? No, it's not a HIPAA violation. Actually, it's covered under HIPAA for continuation of care and for quality, facility quality improvement. I'm happy to send you that information if you'd like to email me, but this is actually covered under HIPAA. How are we to extract the discharge date if not in our hospital system? So you'll need to work, you'll either need to follow up with the hospital that they were discharged to or the surgeon who performed surgery on this patient. The surgeon leaders of the STS will tell you that no surgeon will perform surgery on the patient, send them to another hospital and not follow them. So you'll need to either work with your surgeon, your surgeon's office, or the hospital that they were discharged to get that information.
Another great resource is your medical records department. You could have them reach out to the medical records department at the other hospital. And sometimes that's a good avenue to do that too.
Yeah. Next question. What if the patient died in hospice? So any patient who is discharged to hospice is counted as an operative mortality. Some of our home care services include hospice care. How do we code that discharge? So you would code it as discharge to hospice, and that counts as an operative mortality. What is considered short-term versus long-term rehab? So this will be in your discharge notes from usually from your cardiac rehab or your physical therapy team or whomever is doing your discharge planning for that patient as to what type of rehab that patient is going to. It's also designated through Medicare what short-term and long-term rehab facilities are. And I don't know how detailed you got in the training manual on this, Melinda.
I got pretty detailed. In fact, I was trying to look for the sequence number. It'd be great if you guys, when you put your questions in, you put the sequence number to just so that I could clarify it for sure. But it's pretty granular in the training manual.
Thank you. Are LTACs or long-term acute care considered nursing home or long-term rehab? And LTACs are considered long-term rehab.
Long-term, yeah.
If a patient refuses the medication at discharge, does that still have to be entered as no and then counted against the physician?
No. We've got a real nice description in the training manual about refusal of medications now, but there needs to be a note in the chart detailing that you had a discussion with the patient about why it's important to be on this medication and that they still refuse to take the medication. Then you can code it as contraindicated.
Yeah, the medications that we collect in the database have there's an importance to them, and that's why we collect them. And the surgeons were really hesitant to allow us to code contraindicated on patients that refuse because of how important these medications are in their post-operative post-operative care to get the patients back to being better and protect them from any events post-operatively. So it's really important that there's documentation of education regarding the importance of the medications, and that the patient still refused. If the patient refuses a substance use screening counseling, do we code no or NA? So I would code NA for that if they refused. Why did we get rid of in-hospital alive for the discharge mortality status? We use this when we have patients that are still alive and in the hospital at harvest time. I'm not sure, Shelley.
Because you have this one, is the patient still in acute care hospital setting? Yes or no? I think that we replaced it with that field, didn't we, Carol?
Same thing, yeah, and we just changed it to in-hospital alive to make sure that that it was realized that it could be a continuation of acute care from one hospital to the next. I want to be sure I am understanding correctly. If a patient is discharged to hospice, they will be considered an operative mortality even if the patient lives longer than 30 days post-surgery. Yes, and that includes patients who are discharged to hospice on day 29 and die on day 31. The patient is an operative mortality. The substance use screen for all three will still be within 1 year. I believe it is within 1 year. Melinda provided the NQF measure, or link to the NQF measure in the training manual, and I believe it's NQF measure 2795.
It's 2597 is actually the number. I'm looking at it right now. And the time frame is 24 months prior to the episode of care until discharge of the episode of care. So it's 24 months you have for this screening.
Thank you. So if they smoke and drink and only get counseling on alcohol, how do we code? So you would code this as a no. They have to, if they are screened positive for 2, the smoking and the drinking, they have to get counseling on smoking and drinking to code yes. If more than one type and only one is counseled, they have to receive counseling on anything that they would screen positive for. If patient is on medical marijuana, is that always then a yes to tobacco use? Therefore, what? No.
No, that's not tobacco use. It's only tobacco use if the medical marijuana is wrapped in tobacco leaves.
Right. Right. 2795, non-prescription opioids also includes methamphetamines, THC, and other illicit substances in the screening. So it's non-prescription. I believe it's non-prescription medication.
It's non-medical prescription drug use and illicit drug use.
Yeah. I'm going to pull it over here. And so here's the NQF measure. It's preventive care and screening, tobacco use screening, and where is it at? That's not the right one. Let's see if this guy will open. This one. Okay, so who were screened at least once within the last 24 months for tobacco use, unhealthy alcohol use, and non-medical prescription drug use, and illicit drug use, and who receive an intervention for all positive screening results. So I think that Melinda put a link in the training manual, and I think it goes to this page or a page very similar to this, and it will give you the detailed information about who and what you're screening for. There's specific tools that are used for these types of screenings, and it's up to the site to use a tool that's validated. That's all part of the NQF measures, and that's how they, it's the site who chooses the tool that they use for the screening. Does screening require drug screening serum?
I don't believe so. I think what it requires you to do is to ask the patient, do they use illicit drugs?
It's just like any screening we do for the CMS core measures. What if the patient's discharged to hospice, but we don't know when? We don't know when they die. Can we say yes to mortality, then not have a date? No, you really need to have a date in that field. And you can find that date either through however you need to find it. If you need to go to the obituaries or you need to call the surgeon's office, but you need to provide a date. Otherwise, it'll count towards your missingness. Is discharged alive, died after discharge considered an operative mortality? So it depends on when the patient dies. If the patient is discharged alive and dies within 30 days of the surgery, then it's considered an operative mortality. If they discharged alive prior to the 30 days, but they die after 30 days, then it is not an operative mortality. If the patient on home hospice dies at home, is the location of death home or hospice? It should be coded as hospice, right, Melinda?
Yes, yes.
A patient can be on home hospice for some time. Are we determining on 30 mortality status follow-up that they were operative mortality versus recovered? How long do we follow hospice patients for? Most patients who are discharged, it was almost 100% of patients who were discharged to hospice expired within the 30-day mark. So like I said, it's a very small number of these patients who are discharged to hospice and who survive after the 30-day mark. The patients are only recovered once they're discharged from hospice. So if you have a patient who's discharged to hospice and they stay in hospice for quite a while, that patient will have to put the mortality date for when that patient expires, and they would still be considered an operative death. If they remove that patient from hospice service and no longer continue hospice on that patient, then you should email into the FAQ mailbox, and the surgeons will need to review the case and can help with how we should code that patient. So that's how they would like to do that. Does it count against anything if a hospital decides not to follow deep sternal? Oh, no. If you don't follow your deep sternal surgical infections, deep sternal wound infections for 90 days, it's up to you if you want to follow those or not for this version. I do not know in the next version, which will come out in 2023, if we're going to make this a required field. There has been some push from some surgeons who would like to follow this out to 90 days. Right now we're not doing that, but just keep it in mind that it may be something that we do in the future, not for version 2, not for this version though. So it's up to you if you'd like to follow these patients for 90 days. How would death by an accident unrelated to surgery be coded for 30-day mortality? Unfortunately, if your patient is discharged from the hospital and then dies within the 30 days, regardless of the cause of death, they are counted as a operative mortality. We've had patients who have died by very horrible accidents that we've had it code that way, and it's the surgeons, all of the surgeons are playing by the same rules. It doesn't seem fair if a patient is transferred to another hospital and has any post-operative events or medications missed on discharge that affect star ratings to count against them than the operating hospital. So it's we're following the patient's care. So it's important that the surgical teams work across, or the discharge teams work across the spectrum to make sure the patients are discharged home with the correct medicine to ensure that their care after surgery is safe. And that's the importance of following the patients when they're discharged to another acute care hospital. Maybe I missed it, but where are the COVID-19 questions not on this? But are the COVID-19 questions not on this new 4.2? No, I'll be adding those in a few. I'll be adding those along with a couple other corrections I need to make on the form, and then we'll be posting it before it go live. Regarding tobacco use, I saw in the definition the training manual reference to vaping. Are we to capture vaping as tobacco now?
Yes.
Yes. Thank you. please review, I think I reviewed, if you need me to review it again, Paula, on the discharge to hospice operative mortality, let me know. But any patients who is discharged to hospice is considered an operative mortality. What is the differentiation between short and long-term rehab? This will be coded in your by your rehabilitation team, either cardiac rehab or physical therapy within your hospital, whoever helps make the discharge plan as to the intended outcome for that patient. And it's also, it will be, the short term will have a definite goal and long term is more of an acute care type thing. Also, a skilled nursing facility is just supposed to be captured in this question as well. So SNFs go into the long term, is that right, Melinda?
Well, SNFs can go either way because they use the SNFs for two different things. Sometimes they use SNFs for intensive care, that and they're going to be there a long time. Other times they use them for just rehab places. So you really have to kind of investigate what the intent of the discharge is and why they're putting them in that facility. And case management, generally speaking, has a great insight into that and usually documents that quite well.
Yeah. Okay. The next question, thank you. And it's really important just to read the documentation. What if the patient is on hospice prior to surgery? Please email us if you have patients on hospice prior to surgery. I'm sure the surgeons would like to review that and provide guidance on those patients. If the hospice patient dies 34 days from operative procedure, is it still an operative mortality? Yes, any patient who's discharged to hospice is an operative mortality. Will I start using the new verse for the cases starting in July or for the June cases? Oh, the new version will start with OR dates of July 1, 2020. Version 2.9 ends on June 30th with OR cases June 30th. Version 4.202 will start with OR cases on July 1st. Page 26, 6690, surgical site PO, is it and/or does during initial hospitalization mean if they were in the hospital greater than 30 days? Yep, so this is what's being asked. And that's a great question. This question here, surgical site complication period up to 30 days or during initial hospitalization. So if the patient is in the hospital greater than 30 days, you still need to capture this field. What choice would you make for a patient discharged to hospice and died in hospice? How long after discharge are we to follow discharge to live, died after discharge? So discharged to hospice, died in hospice, that is an operative mortality. Any patients who discharge to hospice are operative mortalities. And then how long after discharge are we to follow discharge to live, died after discharge? So we need the readmission, I believe, is 30 days after discharge, right, Melinda?
Correct.
So you'll need to follow the patient for 30 days after discharge to see if they were readmitted. The operative mortality field is 30 days from surgery or within the hospitalization if they do not go home.
And hospice patients, I think Carol mentioned this earlier, but if they're discharged, they're going to count as an operative mortality, but you need to have a date. So you need to follow those hospice patients. And as she said many, many times before, it's a very, very small number of patients that go to hospice. And most often, hospice patients die very quickly after going into hospice. It's been our experience in the STS database. So there's going to be only, I think, a very, very small number of patients who may live any length of time after going into hospice.
Thank you, Melinda. Okay. It's very small, less than 0.4% of all cases for over a year and a half of cases. It was less than 0.4% of patients were discharged to hospice, and almost 100% of those patients died within the 30 days. So it's a small number, but the surgeons felt strongly that we need to capture these hospice patients as mortalities. Is it mandatory to do all 3 substance abuse screenings on all cases? Is this an NQF for all cases? So It's up to your facility if you do the screening on these cases, but you would mark no if you did not do the screening or provide the counseling that was required. I don't believe we are reporting on this NQF measure, but I'm not sure when, and I'm not sure when we will start reporting on the measure. Right now, we are not reporting on it. Did the post-operative event other get removed? Yep. So I don't think we're collecting any other. These are the only things that we're interested in for post-operative events. The other category is kind of a catch-all, and we can't do anything with it because we don't know what's in there, and we're only collecting post-operative events on the things that are listed here. If there's any other, we're not collecting it.
Right. The surgeons were pretty clear that they just were interested in the complications that are listed on the form.
Thanks. Why was participation in anesthesia section question changed? Well, we added a question if you participate in the anesthesia section, and that was added so it's apparent to that section. Otherwise, it opens up for everybody, and all of these fields that didn't have a parent show up as missing. So this is just to open up this section. Surgeon's worksheets done. I think one of them should be posted online now. I'm working on getting the aortic valve surgeon worksheet is posted. The other ones will be coming soon. If a patient is discharged to hospice but dies after 30 days, yes, that patient will be in operative mortality. There is no perfusion worksheet, but we can certainly make one for the operative section. Right, Melinda?
Yeah. In fact, I think a lot of people out there already have worksheets for perfusion type stuff. So if you guys do, send us some examples in. That'd be great. Yeah.
When will vendors have Proc ID and risk model? So I answered this question already, and we're hoping within the next week or so. So in the anesthesia module, we are capturing dexmedetomidine in both sequence 7414 and 7716. Yes, it's captured in both spots. The one in 7714 is captured in, hold on. The one, this is just within 20, this is the multimodal, 7414. This is the multimodal, it's OR entry to 24-hour post-OR exit. So anytime from OR entry to 24 hours post-exit. And then in 7716, where it's recaptured, this is other post-operative sedation, and there's a time frame specified in the training manual on this. I believe it's 24 hours post-op.
No, it's from to ICU exit.
Oh, from OR exit to ICU exit?
Mm-hmm, mm-hmm.
So it's a little bit longer, a little bit different time frame here. And you may actually double count, end up double counting dex, but the anesthesiologists were okay with that. If a patient is discharged to hospice, do the discharge medications gray out? Yes.
I believe so. I believe so. They do now.
So the discharge medications will open if discharged alive, last known status is alive, or discharged alive, died after discharge. This field here, this field here is the parent to the discharge location, which is then the rest of these. If your discharge location is not AMA, then it will open up here. These will open up. So patients who are discharged to hospice, you do not need to collect the discharge medications. If the primary care physician has done smoking counseling prior to surgery, does it need to be done again? No, you have a 24-month time frame to capture those fields, or that field, sorry. I tried to hear all your videos, but I find them very hurried and confusing. Is there a cheat sheet with the changes, or do you have any other suggestions of how to get through this next week? If you have specific questions, Melissa, please email me or Melinda and we'll help you through. Are we expected to call rehabs and LTACs for patients' status? Well, you need to follow your patients for 30 days. So however you need to get that information, this is no different than what we've been doing in the previous versions for these cases. So you need to follow your patients for the 30 days post-discharge. And you need to answer the questions, either if it's called the rehabs and LTACs, or if you have to call the surgeon's office, or some sites even reach out to the patients. You can follow them on Facebook, or however you need to follow that patient. That's what you need to do. And you also need to keep a record of your, for auditing purposes, keep a sheet of if you're checking mortality status or you're checking readmission status. You just need to keep a spreadsheet or something like that. So if you're audited, all we're looking for is that you checked on the patient, that you had a method to follow the patient after surgery. Will the risk model be functional in the new version? Yep, it will be the same risk model, just a few mapping changes for the new version. Due to COVID, we are not doing ORTEs with cabbage cases. We use ORTE to answer pre-op echo if none are done, but you're not doing them in the OR. Can we have in the echo section pre-op no for when no echo done? Otherwise, we are missing in all of those fields in pre-op. Hold on.
Yeah, we don't have a parent that says, did you do an echo? So in those situations, if you have no pre-op echo at all, the questions that...
Well, I mean, you just select no here to the dimensions available, the fraction done.
Right, you say no to this, no to this. Regurgitation, you say no because you've got no documentation that they have it.
Right.
You say no to stenosis because you've got no documentation that they have it. And same for disease.
Please highlight the last minute changes next week. We have already worked on finalizing our data collection tool, and it's difficult to work with since columns that you move sometimes affect other. So I'm going to show you a trick one day, Tina, on how not to make your columns do that. Not an easy process, and have worked on it for 3 days. So if you have columns like this and they're going to move, I'm just going to show you real fast for people who like to do their own forms. If you highlight things, you can actually move this itself instead of affecting the other things. So if I wanted to just move this one and not affect that one, I would just highlight both of these, and then it will only move this one. Just a little trick, Tina. But yes, I'll highlight my changes. When will the last harvest be available? So that's harvest 1, 2020, and that should be available. It'll be available this summer, hopefully within the next few weeks. Post-operative event for surgical complications within 90 days have the options of yes, infection, yes, non-infection, and no. There is no option for abstraction if we are not following the patient. No, that's incorrect, Kathy. So in the post-operative section, I think you're looking at the wrong form. Okay. In the post-operative section, we have the yes, infectious, yes, not infectious, yes, both. And then that's where you would capture these. This field, this 90-day field is not part of that question. If you're not following the patients for 90 days, you would just select unknown here. The blue comes out very dark. Will it be removed in the final form posted? There's a form posted without any highlights on it already. Was there a webinar that went over the section A to H prior to the operative section? Yes, we started these webinars in January, and it's the version 4.20 upgrade, or the upgrade walkthrough. They were the last, I believe, the last week of each month. And then in June, we went, all of the webinars in June have focused on the upgrade. Can we have an unknown response for 7005? Let's see what 7005 is. No, it's either yes or no. You need to know where your patient's at. The patient just had a major operation, so you need to know where that patient's at.
I think maybe if you explain, this is a field so that if your patient's still in the hospital during the harvest time, you can say yes, and then you don't have to, fill out the rest of this stuff. That's what that field's there for, basically.
Is the patient still in the acute care hospital setting? Yes or no? So either the patient is in the acute care setting or they're not. If you should really know where that patient is at. I'm not sure how you would code a no there. If they're still in the acute care setting, then you don't fill out any of the discharge information until they're discharged. Once that patient is discharged, then you would change this answer to no, and the discharge fields would open up.
Right, right.
Would you please explain the platelet dose pack in 6581?
Okay, so let's say there's a bag of platelets, right? And in this particular bag that you're given the patient, different bags can have different dose unit packs in it. So one bag might have 6, one might have 10, one might have 8, but you're still given that one bag. So we're going to count the one bag as 1. If you give 2 bags, we're going to count that as 2. Does that make sense now?
Mm-hmm. And it's in the training, it's really clear in the training manual. I think it's important that when you start abstracting for this version and any new versions that come out to get familiar with the training manual and what's in there for the first, for the cases that you start abstracting with. And then make sure you check the updates every month that come out so you can see any clarification that was provided during that month. In the PowerPoint slide, time spent abstracting an average case, it would be important to know what hospital physicians are using the surgeon worksheets. 1 to 2 hours seem very low for complicated aortic cases without a surgeon's worksheets. Yeah, usually I would say that the aortic cases probably take about 4 hours to abstract for those tricky cases. But again, the people who responded to the survey, this is what we collected on. And we do have data on the surgeon, on how many people use the surgeon worksheet. And it was probably, I think it was around 60% yes for the aortic section, which was it was either 60 or 70% for the aortic section, which was really good. When we enter TAVR into the database, they are not intubated in the OR, so they are not extubated. They are done under MAC, so we would enter NA to extubation time, right? And TAVRs don't need to go in the database unless you enter them, unless your site wants to double enter between TVT and the STS database, adult cardiac. When it's not infection, the options only relate to sternal wound.
Yeah, exactly. They're concerned. They're interested in the dehiscence.
Yeah, the only thing we're interested in is the non-infective sternal wound dehiscence. And
in this version, it's going to be we're going to follow that dehiscence, sterile dehiscence for 30 days, different than version 2.9, where we only captured it, during the episode of care.
I'm sorry, I may have missed the answer for this. Is there a date yet for when the direct data entry to IQVIA will be? And my understanding is there's no extra fee. There is no extra fee. If you're interested in more information about the direct data entry, then please email stsdb@sts.org, and that email is in the chat box. You can find it in there. And the plan is that it will go live with the start of this version, so July 1st. Not a question to do with today's info, but is the complete 2019 STS analysis available yet on the dashboard in IQVIA? No, it should be coming in the next few weeks here. Could you please show again where to find the poll results of the time to abstract a case? Yeah, sure. Absolutely. So I'm at sts.org, and this is the home page. Under Registries and Research, and I know my page is kind of jumbled up here. Let me move this over. Under Registries and Research, go to STS National Database, and then this page will open. Don't click on any of these links. Scroll down a little bit on this home page of the database, and you'll see data manager education here. Click on that, and then we have the data manager survey results here. And it'll open up. These are the 2019 results, and we're probably going to do another survey, but more towards the end of the year, once people start using this new form, and we're going to ask different questions. These questions have just been pretty static over the years, so we might switch it up a little bit and get some more information from sites. I do not think it's reasonable for us to ask us for more information on patients discharged to rehab or LTACs. These places can be out of state. These places are not required to give information back to our hospital. So I'm not sure what more information we're asking for. These are your discharged patients that you need to follow to make sure that they're not readmitted. And your surgeons should absolutely be in contact with wherever their patients are being discharged to following a major cardiac surgery. So if you need to reach out to the cardiac surgeon's office, then that's what you need to do. If you need to establish some type of communication between your quality department and the surgeons, then that's what you should do. If you need to call the rehab facility to get follow-up on the patients, it's really important to make sure the patients are doing okay, not for you, but for the surgeon, and make sure that what your hospital performed on this patient, that it went well and that the patient's not having any complications following the surgery that was performed at your hospital. Due to HIPAA, it is sometimes difficult to follow for all complications post-op. Only item that is easy to get is their DC date. Has anyone else experienced this problem of getting specific comps once they leave your facility? Sure. So you have to work within your facility, either like Melinda said, through the medical records department, or you have to work through your surgeon's office, or you have to work directly with the quality department at the other facility to get their information. And it is under HIPAA that the cross communication between hospitals is covered under HIPAA for quality improvement and for patient continuation of care.
Yeah, and again, I think medical records department is a great resource. You know, you go down there to your medical records department and you say, I need these medical records for this patient that we transferred. They will reach out to the other hospital's facility, and I would say 99% of the time, the other hospital is going to send those medical records to your facility.
Yeah. Is a vent facility considered an acute care setting for vent waning? Melinda?
And that's more like a long-term. Generally speaking, that's probably an LTAC, but.
Yeah, if that's all that, I would check to see what type of facility that is. If it's an LTAC, which is usually where the vent weaning occurs for those patients that are discharged on vents, usually it's an LTAC, and that is not considered an acute care, a continuation of the acute care setting.
Right, we need more information, Heather, because I have seen where sometimes a patient will come from another hospital, which is an acute care facility, have a surgery, and then go back to that other hospital because their family lives close there. So it depends on the type of facility that the patient's going to for that process, that vent process.
When a patient is thanks, Melinda. When a patient is discharged to live died after discharge, if they expired greater than 30 days from surgery date, then operative mortality equals no? Question mark. Incorrect. Operative mortality equals yes. Any patients who are, oh no, I read that wrong. You're correct. Sorry.
You're correct.
I'm so stuck on these hospice questions. And I'm like, they're going to kill me if I read another hospice question. If a patient is discharged to live died after discharge, if they expire greater than 30 days from surgery date, then operative mortality equals no. Correct. Patients who expire greater than 30 days from surgery and who have been discharged from the acute care setting are not operative mortalities. When patients are transferred back to another hospital, we don't have unlimited access to those records. There have been times when I'm happy just to get a date of discharge over the phone. For audit purposes, how are you expecting us to verify anything that has happened after they were transferred back to the original hospital? So this is actually, some sites have no transfers, some sites have more of the transfers. It's a small number of patients that are transferred back. For these patients, you have to do your best to get the information. This has been in place since the start of 2.9. So it's not, or actually I think the AQO after 2.9, so October of 2017. This is something that has been in the training manual. This is not a new change for version 4.20. So it's important that you work on your process either internally or with, like Melinda said, through your medical records or with your surgeon's office to get these records on the patients. The surgeons are following these patients. They know what's going on with them. And they've been in contact with the other facility, checking on their patients probably daily. So whatever process works for your hospital, you'll have to discuss it and figure out what works for you. If a patient was discharged to hospice but still alive after 30 days, oh no. If the patient was discharged to hospice but still alive after 30 days post-op, do we continue monitoring to capture mortality date? Correct, yes, continue monitoring to capture mortality date on that patient. It sounds as if following patients for 90 days is optional. Is that correct? Yes, that's correct. Please clarify if patient has HITT, do you code yes for both HIT and HITT, as HITT is worse from a form of HIT? Correct, you would code both to those questions. If you code yes to HIT, then the next question, the child of HIT coded as yes is HITT. That then you would answer that question. And if the patient has it, then you would code it. Will the 90-day follow-up for sternal infection, will it get uploaded in time for our harvest due dates? It seems that the harvest due dates are about 45 to 60 days from the quarter to be uploaded. So probably not, but if you capture that, it'll eventually get into the system. For those cases that are greater than out of that time frame, they'll be uploaded in the next harvest. The substance abuse counseling is NQF. Is it going to be in the star rating now? No, it is not. The substance abuse counseling is not included in the star ratings. I don't know if that's the plan, but for right now it is not. And I don't know of any plans in changing any of our star ratings. For post-operative stroke who has a left extremity paralysis greater than 24 hours, do we code both?
No, the paralysis greater than 24 hours field is related to spinal cord ischemia, not stroke.
Thank you. So a PEG insertion is not going to be considered at re-op other non-cardiac. And I can't remember what we said on this. I may have answered it incorrectly before, but did we change our mind on PEGs for version 4.2?
Well, PEGs generally aren't put in the OR anyway. I mean, so I guess it's institutional practices. Most of these are done in like GI labs. So Heather, why don't you send me a question if you've got a specific question related to a specific patient, so that we can work through where it was done and all that kind of stuff. Because sometimes I know if your PEGs are done in the OR, I know we talked about that before, and I think
we did talk about that before, and I think different sites have different resources available. Some are able to do them at bedside, some are not able to do them at bedside. And I know that we had discussed that with the surgeons. So we
right. And I don't think PEGs, yeah, it's real clear. It's in the training manual. Here it is. That's what I was looking for. I was buying time, guys. This does not include procedures performed outside the operating room, such as GI, lab for PEG tubes, shunts, dialysis. You know, so practice patterns affect this. I don't think I would capture a PEG tube as a return to OR unless they were doing, I don't know. You know, I had to know more about it. Generally speaking, those are fairly minor procedures.
Okay. Next question. So we do not have to capture C. diff? No, we're not capturing C. diff.
She talking about GI event, I'm assuming. We used to capture that. Let's see, with the new training manual.
I think it would just go into the other if you wanted to capture it.
Yeah, I think it goes into the other. That's what I'm looking for to be specific. Yeah, we are still capturing C. diff. And in the training manual, it goes in the other bucket. That's why it's important to read the training manual, guys.
Can you add multi-system failure to cause of mortality? So the causes of mortality were listed here, and I think if it's a multi-system failure, oftentimes those are related to an infection, and that you would code infection. But if you need us to review a case for you, send it in if it has multi-system failure as the cause of death. I can't open the new training manual. You should be able to open it. I can open it. I'm using Chrome and it's opening. And I've opened it in Internet Explorer, so you should be able to open it. For sequence 6901, post-op insertion of devices should say permanent device, not pacemaker, FYI. Thanks, Heather, for the information. If the patient was readmitted because of the superficial sternal infection, we should code 7160 wound other. Well, hold on, let's get to 7160. If the patient was readmitted because of superficial sternal infection, we should code 7160 wound other. Well, if because of sternal dehiscence, we should code wound sternal dehiscence not related to infection, right? That's within the 30 days, right, Melinda? So if they were discharged.
Well, yeah, I'm trying to read her question. I'm trying to process it. If the patient was readmitted because of the superficial sternal wound infection, would we encode wound other? Probably, because the wound sternal dehiscence is for a sterile dehiscence, not infection. So yeah, that's probably, if it's a superficial sternal wound infection, I'm looking at the choices, wound other would probably be the best spot because wound sternal dehiscence is not infectious.
Right, and we would capture deep sternum mediastinitis over here on the other infection side.
Right.
I agree with that. I think that's a good one. Okay, please review how or when to capture post-op cardiogenic shock.
We don't have, that's not in our database. We don't capture post-op cardiogenic shock.
And I think she's asking if the patient does have post-op cardiogenic shock, how do we capture that? And we don't capture it. You would just capture on the events that were attached to that, right, Melinda?
Yeah, so like if they were intubated long because of that, or if they had to have a balloon pump put in because of that, or if they had to go to the operating room for bleeding because of that. So you would capture, we just don't have a separate field for cardiogenic shock.
Yeah, we capture some of the cardiac reasons that would make up that, the parts of the cardiogenic shock that we would be interested in. What if they are discharged to a hospice for a reason other than cardiac? They're still considered to be operative mortalities. Correct. Yes, if your patients are discharged to hospice for any reasons, they're still considered to be operative mortalities. Regarding a patient that is discharged to another hospital, if we contact that hospital and get the information needed but do not have documentation, how is this handled in an audit? That's a great question, Rebecca, and I think probably the best way to do that is document your information that you obtained and who you talked to, and just keep it as part of your records. Melinda, what do you think about that?
Yeah, I'm thinking that's probably the best way to do it. And then if you were audited, that would be part of the information you'd send to the auditor if that record was chosen in the audit.
Yeah, I would just do your best to try to get the actual information. It is covered under HIPAA, so it would be helpful if they could just send it to you. And oftentimes it's medical record to medical record departments that need to speak to get that information.
Right, and I've seen it a lot. The medical record department will get it and they'll get it scanned. Like if you have Epic, it'll just scan it into the media section and there it is. Just like any other hot patient that's transferred, the patient gets transferred to you, most often you have those records from the hospital it was transferred from. So medical records is a really good place to get this type of information.
Yeah, thanks. My question is that if we say operative mortality when people go to hospice, other fields are going to open about date and circumstances of the death that we may not know. They could be in hospice for months. My suggestion is like I said, it's very, very few patients who survive longer than 30 days who are discharged to hospice. Probably less than a tenth of percent. It's very small. But for patients who do go to hospice, there's a couple things you can do. You may want to not, and Melinda, tell me what you think about this. Maybe not submit this case over to, I'm trying to think of how you can exclude it from the analysis, or if you need to exclude it from analysis for anything, because you check discharge to hospice, you're still waiting on these questions. And I think that you can exclude these from being submitted in your vendor software for these patients. It will be a very, very few cases that you would ever have to do that to. So I think you probably just have to work within your vendor software to not submit them until you have the complete information on them. If you're having problems and you get to this part where you have a patient who was discharged to hospice and the harvest is going to close and the patient's still in hospice and they've been in hospice for 2 months, please reach out to me or Melinda, and we can try to figure out a way to exclude these patients from going into hurting your missingness for the threshold for these fields. Can you please address the difference between acute care and long-term and how this should be abstracted? So acute care, actually it's short-term and long-term. So short-term is that the patient has a plan and they're going to be there. It'll be documented that they'll have a plan and they're going to be in rehab. The goal is for 3 weeks, and their plan is that they're going to return to their, able to perform their ADLs and things like that, where they'll be able to get back to their level of functioning or near to their level of functioning prior to surgery and no longer require any type of physical therapy or inpatient or short-term rehab like that. Long-term acute care facility are patients that are more dependent and have more acute things going on with them. The goal for those patients is that we're just maintaining them, and they may get better, but it's going to take a really long time for them to even get there. Maybe these are patients who are just super debilitated. They're not even able to do any type of physical therapy, and they're not even at that point yet, but they can't stay in the hospital any longer. They need to get moved out. So it's those patients that are just long-term care is the very debilitated patients. This will be charted in your either by cardiac rehab or physical therapy or whoever does the discharge planning, and they'll help, they'll chart what the goal is for the patients when they get discharged. So I think that's probably the best place to look. What about patients who are on comfort measures only rather than hospice? Are they considered operative mortality even if they live more than 30 days? Want to take that one, Melinda?
Well, my first question in reading this is, are they still in the hospital on comfort care, or they've been sent home on comfort care? And if they've been sent home on comfort care, is hospice providing the comfort care? So I need a little more information on that one, Katie, because if they're still in the hospital and they're on comfort care and they die more than 30 days, then they're a death, because that's the same hospitalization index procedure. If they go home on comfort care and hospice is providing that comfort care, well, then they've been discharged to hospice. So need a little more information.
Great. And I think sometimes patients are put on, they might be in the ICU and they might put them on comfort measure only prior to hospice, seeing that patient and doing their evaluation and all that. That's different. And that would be, I would still say reach out to Melinda and review that case with Melinda if you aren't sure. My guess is that patients who are in the ICU and go on comfort measures only probably have an order for hospice evaluation in the chart. And a couple questions about alcohol screening, abuse, and what is unhealthy alcohol use. So there are tools, and the tools need to be, this is what we kind of, that goes along with the CMS core measure idea, that it's a validated tool that's used for screening. There are specific tools that are used. It's not up to STS to define those tools. It's up to your facility to use a validated tool to screen the patients. So the question is, alcohol counseling, is that for 8 drinks or greater per week? And it's whatever your tool defines as having unhealthy alcohol use. On the substance abuse, what happens if we have yes for drugs but unknown for alcohol and tobacco? How do we code 2595? I think it's 2597. But I think if you have a yes, you have to provide screening for whatever answer you have a yes for. Does that sound right, Melinda, from what you've learned about it?
It sounds like we have a yes for drugs. So they were screened for drugs, but they weren't unknown for alcohol or tobacco. Then you're gonna have to, I don't understand why unknown for alcohol and tobacco. It seems like you have to screen for all 3. That's part of the measure. You have to screen for all 3. So if the same patient can tell you they don't have drugs, why can't they tell you they don't have alcohol or tobacco? So the first part of the measure is screening. So all 3 have to be screened. And then if there's a problem, you have to counsel the problem areas.
Thank you.
So there's a requirement to know, is what I'm getting at, I guess,
Okay.
whether the patient has unhealthy alcohol or tobacco use.
So if a patient was screened at the doctor's office before admission and counseled, is that acceptable to code yes?
We have 24 hours, and 24 months, good gracious, 24 months prior to the episode of care. It goes all the way through discharge. So yes, that is acceptable.
Yeah, that's good to know. So if the patient, that's a great question. So if the patient screens yes at the doctor's office, they receive appropriate counseling within the 24 months prior to surgery, then it would you would be able to code yes for those, as long as all 3 of the as long as, I think, right? As long as all 3 are met. What did we just say?
You have to screen for all 3. And then if there's a problem in one of those areas, then they have to be counseled. If this is done at the pre-op visit or an office visit prior to the episode of care, and it's documented, then you can say, yes, it was done, because we have a 24-month window prior to the episode of care, and then the window ends with the episode of care. So if you have a doctor's office pre-op visit that screens all, and they were counseled appropriately, if they had an issue in any one of those areas, then you can say, yes, this was done.
Thank you. Is status at discharge 7007 a child of field of is patient still in acute care setting? So status at discharge is this field here. And so this field here is patient still in the acute care hospital setting. And if you answer no, then the status at discharge field will open along with the hospital discharge date. Then these fields will open. So it is a child of his patient still in the acute care setting. Here's a statement: we do not talk to patients. So I have called patients as an abstractor just to check on them or to see if they have been readmitted. When I was working for the surgeon's office, I do the same thing. So some people do talk to patients, Michelle. Next question. For sequence 7140 readmission, is it still necessary to have specific documentation of no readmission, or can we code no if there is no documentation of the patient doing well and or progress expected? If you don't have documentation of the readmission, I think we have to prove that the readmission happened to code the readmission. We don't want to assume yes. So if you don't have documentation that the readmission happened, then you would code no, but just make sure that you keep a tracking document that you can, that shows that you did do some type of steps to check on that readmission of the patient, whatever it may be, because that patient may be at your hospital and then they may get discharged 3 states away. And there would be no way for you to know that that patient was readmitted at your hospital. And it's not like you're going to call hospitals 3 states away and do, hunt that down. So to see if they were readmitted. So you would just check if you called the surgeon's office or if you checked in your EHR or whatever that may be to do your tracking. Just make sure you keep track of how you're checking to see if those patients were readmitted. Okay, I guess we're at time. I'm going to do one more question. With the NQF measure, 2597, will the NQF measure also be included? No, it will not be included in the STAR NQF report at this time. Let me see if there's any other questions in here before we go that we maybe haven't covered. What if the patient died at the other hospital he or she was transferred to? If it was if they went from another acute care hospital to from your acute care hospital and that patient died, it counts as an operative mortality. Do you see any in here?
I'm looking through them. There's a hospice.
Oh, here's a good one from Beth. Do we need to save proof that the patient was alive at 30 days? For instance, we call the cardiologist's office. Do we have to get and save that office note? Or if we can find an office visit on the, I guess it's on the chart, must we print it and share it? So I think you can just, I believe, Melinda, is this right, that you can just say that call the cardiologist's office, saw patient in the office on such and such a date, or whatever that, or you can just say call cardiologist's office, verified patient was alive at 30 days. And I think that can just be kept on your tracking sheet for audit purposes.
You can. Some people just staple like a little piece of paper to their sheet and say, oh, I called this day, he's alive, he wasn't readmitted, he didn't have an infection. And you sign it and, when you did it and the date. Other people tell me they might just keep a little Excel log, and same concept, but you've got it on a little Excel log. You just got to have some sort of log that if you were to get audited, you could show your process, and that you've actually done this process.
Great, thank you. Robin is requesting that we transcribe all of these questions so she can have a PDF of them. And I would say, Robin, if you'd like to transcribe, you can certainly go ahead. I'll be happy to send you a panelist link. But I don't think we're going to type them out. We've already answered 139 questions today, so we don't have the resources to do that. Sorry. Let's see. Did you see any other good one in here?
Okay.
They're all good, but anyone that maybe.
They're all really good.
Yeah.
LVADs, standalone LVADs are optional. They don't have to go into the database. There was a question from Kristen about that. They're supposed to go in Intermax standalone LVADs. You can optionally insert them if you'd like. They're not required.
Yeah, and this is a good question too, because we are seeing more locum tenens. How do sites that use locum surgeons follow their patients after transfer to another acute care facility? I do not believe these locums follow patients after they move on to a different site. Does the physician's responsibility for follow-up fall on the quality department? So actually that physician, hopefully, I believe, that physician should be connected with some type of office or somebody who is following that patient, especially within the 30 days following surgery, because it is the physician's responsibility to be managing their patients. That could be neglect of care, and I believe there's legal things that go into that if they don't follow their patients during that time frame. That actually, and most surgeons would never not follow their patients for the 30 days. So I would say that that's a hard one, and I know some sites are really large, they have locums, and it's hard to keep track of everything that's going on or everybody that's going on. Some sites do not. This is a thing you can work out with your locums. If you are going to collect their cases and you're going to add them on to your STS database, have them sign a Schedule A and all of that, then maybe one of your conditions is that they do follow their patients even after their time with you is done, and that you can make that arrangement with them prior to them signing on. If your surgeon, your locums doesn't care to do that, then maybe an option is that you don't collect their cases in your database. So that is an option to do that.
The question right under that, Carol, where is the training manual? Can we just please show everybody where that is?
Oh yeah.
I think that's an important question.
So I'm going to go, this is the STS homepage here, sts.org. And then you would go to the fourth blue box at the top here, which is Registries and Research and STS National Database. Either way, you click here on the STS National Database, and then you have the 4 databases button, the buttons up here or on the side. Adult cardiac is this one, and then the access data collection resources, and then under version 4.20. And the training manual is right at the top here. One surgeon worksheet is posted. I just got posted a short time ago at the beginning of our call. So I have the other ones I'm working on, and I'll get those up soon.
And scroll down and show this other person wanted to know where the inclusion document was.
Oh, here, and the case inclusion guide.
Oh, here's a comment from Katie. We send patients to a local SNF for end of life, not on hospice. So they're sending them there instead of hospice. That's interesting information, Katie.
Yeah. And Kathy Kane says if the patient is emergent or salvage, no screening done. So that's where you would check I think there's an NA option there for those patients. But again, you can go back 24 months to check for that if if you're able to. Otherwise,
and you can go through the whole episode of care too. So after the surgery, you can still screen for them.
And KF McKenna found the training manual. And Hans asked, aortic endarterectomy is noted now in which field? That's captured in the.
I don't know what Hans is speaking about.
How about, Hans, if you could send an email into the STS FAQ mailbox, and that's on the STS National Database page. If you scroll down on the National Database page, you'll find the clinical questions request form. If you could submit a question here, we'll be happy to answer that for you.
Bonnie, post-op ICD, unplanned goes under rhythm disturbance, permanent pacemaker. I think that's what it's called now. I don't know the sequence number, but it's that requiring a permanent pacemaker device. That's where your ICD goes.
And then earliest date to enter using the version 4.20 is July 1st. OR dates of July 1st. That was for Kevin. And then, okay, I think we're gonna have to go now. I'm sorry guys, but it's been a long time. I appreciate you joining and hanging out with us for a good part of the afternoon, and hopefully we gave you some good information. I apologize for any confusion. We're gonna check into these other little things that we found today, and there will be a clean data collection form, all the blue stuff and any changes that we make noted, so you can easily find them. Probably I'll highlight them in a different color instead of blue, so you can see it on there. And other than that, I guess our next webinar, when is our next webinar?
It is next Wednesday.
Oh yeah, we have a webinar next Wednesday, and this will be our monthly call with IQVIA, and we'll be getting updates from IQVIA. Hopefully we have some type of update on the status of the quarterly report that's due out, or that was due out. Other than that, I think we're good with the walking through the data collection form. We may do some more focused sessions on some of the sections we were seeing a lot of questions on. But we're happy as we continue on with the rest of the webinars, for the next several months to answer any questions that you have on the data collection form, or please submit your questions into the FAQ mailbox. Submitting them into the FAQ mailbox gives us a way to track them, and then we can always go back to the surgeons and make sure that we're collecting things on, we all have the same understanding of how field should be collected. So thanks again for joining. Thank you, Melinda, for
Thank you.
Thank you, Dr. Warmuth. If you're still listening, I see you're there, but thank you for joining. And thanks everybody for taking time out of your day, and please reach out if you have any questions. All right, take care.